I think that we've made a great deal of progress in understanding what mucus does, and particularly how it's relevant to many chronic airway diseases, especially to COPD. In terms of your specific question, there has been more evidence of interaction between mucus and bacteria. In terms of developing resistance, there's certainly data about the development of biofilms, which is not quite the same as mucus in microorganisms, and that can be a particular problem, particularly with some microorganisms. This is work that developed originally from studying cystic fibrosis. These ideas are now being looked at in the field of COPD. In terms of COPD in general, we are understanding that mucins and mucus, particularly the type of mucus characterized by the mucin that's within it, is very important and is a marker of worsening disease progression. It's certainly associated with having more exacerbations. And there's elegant data now really coming out of the US, which shows this to be the case. So this field has moved forward quite rapidly, and I expect to see further progress in the next year or two. I think our understanding of the microbiome has been a major step forward. In fact, it's given a new lease of life to research in lots of chronic airways disease, not least COPD. I think we've got a better insight into the complexity of the ecology of the lower airway flora and how that changes when exacerbations occur. And clearly we're looking at bacterial infections, but also how they respond to viral infections. And we are getting more sophisticated as a result of that in terms of how we classify exacerbations and understand the characteristics of patients who exacerbate frequently. And that's particularly associated with changes in the amount of proteobacteria. And we're beginning to partition exacerbation events according to this, with the bacterial events no longer based simply on culture positivity, but on more sophisticated analyses that will give us insight into how the microbiome interacts with the damaged airway to produce problems in disease, and particularly exacerbations. I think mucoactive drugs have had a bit of a difficult time. Partly it's because scientifically we didn't think mucus was that important. It was seen as a sticky barrier substance that lined the airways and was clearly a problem to patients, but wasn't a major driver of disease. And for the last 30 years, that's been the prevailing view. Based on the new science that I was referring to before, I think our ideas are changing. The other thing is that traditionally mucoactive drugs, when given to patients, didn't do a lot of the things people initially thought. So breathlessness was not particularly influenced by taking a mucoactive drug, and people said, oh, much better to give a bronchodilator. But in reality, if you look at the drugs appropriately, you'll see that they do have an impact on infections. They have an impact on exacerbations of disease. And they're particularly relevant because they're so well tolerated in patients at the earlier phases of evolution of chronic airflow obstruction. So very much it's the sort of person who has persistent chronic bronchitis, then developing airflow obstruction into the gold, mild and moderate spirometric severity classes, where mucoactive drugs can be really very valuable as a way of preventing problems and improving symptoms. So it's a matter, I think, that they've not been used because they haven't been studied in the right patient groups. I think the key messages would be the microbiome in COPD particularly is important, and changes towards more proteobacteria are associated with more exacerbations and an increased risk of dying. But that regular antibiotic treatment simply develops resistant organisms. Mucins play a part in this story and are also associated with disease progression in COPD, particularly mucins 5A and C. And that by providing treatment with an appropriate mucolytic agent, antioxidant agent, like iodostine, you can reduce not only the number, but the duration of exacerbations and their burden on the patient.
Okay, thank you so much again. Hope to
Thank
see you in the Congress.
Pleasure.
Okay, virtually. Thank you.
I hope that's of some use, and I'm looking forward to speaking to my friends in Portugal. I'm only sorry that I couldn't be there in person.
Maybe next year.
I hope so. Thank you very much.
Good morning.
Morning.